Okay, so I just wanted to talk a little bit today about some topics in minimally invasive spine surgery. I'll go through things kind of quickly. I didn't intend for that to go as long. Thank you again, Dr. Meyer. So I have no financial relationships with any companies. I do work with Globus almost exclusively, and they actually gave me some references for this talk. So there's bias included. Goals for today basically define basic definition of minimally invasive spine surgery, brief history of some of the techniques, describe some of the well-established techniques, take a deeper look into 3D nav, robotics, as well as endoscopic spine surgery, and then just sort of revisit the idea of minimally invasive. So what is the current working definition? It's a suite of technology-dependent techniques and procedures that reduces local operative tissue damage, systemic surgical stress, enabling earlier return to function, striving for better outcomes than traditional techniques. So basically, you want to leave the smallest footprint while getting the same outcomes. So currently 1.2 million spinal procedures are being performed annually in the US. So that includes like ablations, injections, and so forth, but spine is obviously a big market. 75% of these, the surgical interventions at least, could be done minimally invasively. So there's a sort of benefit zone, which is in the middle. So on very small procedures, minimally invasive techniques aren't really sparing you much. And then on complex deformities, you're going to have to use so many different tools through so many different incisions that you're actually losing that benefit of minimally invasive surgery. However, there are some unrecognized potential there, and there are lots of people working on doing deformity with MIS tools. So why are people using this more and more? Why do people want to retrain or train differently or do things that are somewhat painful? Well, the technology is getting better. We have better intraoperative imaging and navigation that are allowing us better 3D understanding of patient anatomy in the OR in real time without having to expose things. And then we also have several decades of all these techniques showing again and again that they help with postoperative narcotic requirements, lower blood loss, and then have decreased hospital stays. Patients are also driving this. So there's an interesting study that came out a couple of years ago where they surveyed 326 patients that were getting surgical spine consults. And so the majority of those patients would prefer MIS surgery with no prior knowledge. They believe that MIS is less painful, lower risk of complications, less expensive, and requires lower level of sedation, whether that's real or not. This is what patients think. And they perceive that minimally invasive and open surgery offer similar outcomes and have the same chance of needing reoperation. Most of them said they would seek a second opinion if they weren't offered an MIS strategy up front. And 44% said they would actually travel long distance to get that second opinion. So there are some economic drivers as well. That big number of 1.2 million procedures is actually on the rise. And part of that is because if you look at older patients with spines with imaging, it turns out that 2/3 of people over 65 have some evidence of degenerative spinal deformity. So more and more people are going to be diagnosed with this. They have their back pain and their leg pain, and so these procedures are going up. These patients also are increasingly empowered to drive their own care. So more employer-sponsored healthcare insurance dollars are part of consumer-directed plans. So that really allows patients a lot of freedom in terms of seeking out the surgeon and the technique they think they prefer. So a number of studies have looked at the cost difference between sort of open traditional decompression and fusion techniques and the minimally invasive surgeries. The minimally invasive surgeries have a lower direct cost in all those studies. Interestingly, it comes outside of the OR. So intraoperatively, on average, MIS surgeries cost more. But because the length of stay is shorter, pain medicine requirements are lower, and there's less chance of discharge to rehab, the overall cost is actually lower. We don't have much, so one of the first and most common techniques are tubular retractors. So it was first described in 1999. And basically the idea is instead of an open midline incision, you are making a very small incision and then putting down tubular dilators to displace soft tissue as opposed to cut it, resect it, burn it, etc. I think there still is a little bit at the bottom of the tube, soft tissue that is getting damaged. So it's an imperfect system, but certainly an improvement over prior methods in terms of tissue damage. And so that offers improvement in terms of, resecting posterior elements, destabilization, and so forth. I'm not really going to talk about these because we're short on time, and I think they're a little bit of a scam. So anterior approaches, there's true anterior, so ALIFs, and then anterior that come more from lateral approaches. And these are most commonly used in the lumbar spine. You can do lateral approaches, obviously, to the thoracic spine. They have different advantages, or I guess they are used at different levels. In this paper, they do claim that you can do an ALIF at L3-4. I've never seen that. It would be incredibly difficult. You need a very good approach surgeon, but basically ALIFs are for the lower lumbar spine. Laterals can get you just about anywhere except for L5-S1, and then MIS TLIF you can use just about anywhere. So lateral interbody fusions, I don't do these, I'm trying to learn them, so I'm not an expert. I'll cover them briefly. Patient selection remains controversial. They're probably a little bit overused at this point, partially because they're easier on the surgeon. But they do allow extremely good disc space exposure, so you can put very large grafts in. You can get them very anterior, and if they're lordotic, you can get really good bony apposition and good lordotic correction. It's a really powerful tool if you're doing revision surgery. You can stay out of posterior scar and other kind of nasty anatomy. But they are largely dependent on indirect decompression. So if you have bony osteophytic foraminal or central compression, this will not allow you to address it because you just can't visualize those structures well enough to safely decompress. And then something that was sort of underreported early in the popularization of lateral approaches is the persistent neurologic dysfunction. You're either going through the lumbar plexus, and it seems like 4 or 5% of patients after these surgeries have persistent neurologic dysfunction. So that is not neuropraxia that gets better after a year, it's permanent, which is really a challenging thing in an elective population to know that 1 in 20 or so, or 1 in 25 are going to come out with no quad. So ALIFs, these are really for the lower lumbar spine, generally L5-S1, sometimes 4-5. These are the best of these MIS tools at restoring disc height and lumbar lordosis. So it is a very powerful tool. There is a lower risk of bad complications with this, but when there are bad complications, they're incredibly bad. So large vessel injury, bowel injury, retrograde ejaculation. And for that reason, most of the time, most spine surgeons use an approach surgeon for this. So this is just sort of a slide showing the reality of some of those problems. So I think a lot of us see the horrible back pain from traditional posterior approaches and think that the spine surgeons who use those are savages. But when you have people walking into your clinic whose legs have atrophied, or they die or have incredibly serious medical complications from great vessel injury, it makes makes me a little bit more forgiving toward the open approaches. So indications for these various minimally invasive techniques, all of them are good for disc herniation and segmental instability. The anterior approaches are better for deformity correction. They just allow you to get more lordotic correction at each level. Theoretically, MIS expandable TLIF cage could get you some deformity correction, but it is pretty limited. And then for decompression, TLIF is the only one that's going to allow you direct decompression of neural elements. So if you have nerves that are really socked in, you're probably going to end up approaching things from the back anyway. So it may be better to just do that up front. Contraindications. So you can see the anterior lateral approaches have many more things to think about before you go in. So any bowel problems, retroperitoneal problems, problems with the great vessels are going to steer you away, whereas the TLIFs you can do on just about anybody. And I think this is kind of an important slide to interpret, as some of the studies that show clear benefit in various domains like length of stay, discharge or rehab, and so forth for the lateral and anterior approaches. That's because those patient populations are inherently excluding older, more medically complex, previously operated on patients with osteophytic bony stenosis. So that's something to keep in mind when you look at these papers that show that lateral fusion surgery is a magical cure for spine disease. So meta-analysis of the various techniques, 29 papers reviewed. So similar complication rates overall. Overall similar fusion rates. So even though the interbody grafts tend to be a lot bigger in the lateral and anterior approaches, the posterior approach seems to achieve similar fusion rate. The ALIF, like mentioned before, is the best at restoring disc height and lumbar lordosis. PLIFs, which are the traditional PLIF, we don't really do here, or at least not on the neurosurgery side, highest EBL with those. And then interestingly, the best disability index scores came from TLIF. And then, when you're doing these presentations, you're doing a lot of Google image searching, and a lot of the Google images that came up from my various search queries were actually direct to patient marketing from Dr. So-and-so.com. Lots of private practice spine surgeons are kind of leveraging the idea that was presented in that survey paper that minimally invasive spine surgery is sort of a magical new solution that can get you out of the hospital and back to being young and fit again. And I don't think, I'm not advocating for people to go on internet crusades battling these people, but I think in the clinic, when you're discussing your surgical approach, if it's not a magical 2-centimeter incision that gets you 3-level fusion or whatever, you kind of have to address this type of marketing to let patients know why you're doing it and why you're not doing this thing that's advertised as laser spine, tiny incision surgery. So endoscopy. So endoscopy is something that I'm familiar with. There's a guy at University of Washington named Christoph Hofstetter, who's kind of one of the academic pioneers in the country, who I work with a lot. So I've seen these surgeries quite a bit and taken care of a lot of these patients. And I do believe in this technology. So it's gaining acceptance across the country, particularly successful in decompressions, lower rates of post-op complications, including wound infection, durotomy, nerve root injury, when compared to both open techniques and tubular microsurgery. It's really good visualization. I would argue it is better than through a tube because the water pressure actually tamponades small vessel bleeding, and you have kind of a 360 magnified view that's not as angle dependent. So strengths and weaknesses. The big thing with endoscopic is that it has the highest upfront cost and the steepest learning curve. It is not easy to learn and people do not get fast right away. However, it does allow for awake surgery. That's the only way to kind of confirm your decompression has worked, sort of. The ones that I've seen are not as clean as one would like. Smallest skin incision, all of them can treat any level. Endoscopic is better for length of stay, narcotic requirement, decreased infection, blood loss, etc. All of them have a similar risk of recurrent herniation and CSF leak. So again, drawbacks, very steep learning curve. I don't think I've ever seen a new learner do a single level decompression faster than 3 hours, which is 3 times slower than probably what they would be doing with tubular surgery. Most of the applications of endoscopic spine surgery are treating sort of isolated, herniated, or overgrown, whatever it may be. And anything that gets rid of that is going to decompress a nerve and lead to a good outcome anyway. It'll decrease the surgeon's productivity, and then you have to overcome, or basically get the hospital to pay for it. So the most common approaches are in the lumbar spine, transforaminal, and interlaminar approaches. The equipment, it basically like what you would see for endoscopic third ventriculotomy, with some added spine tools and reamers. So up here on the top left, oh, I lost my little laser pointer. Anyway, on the top left, there's a reamer. So you can actually ream out bone through your endoscopic approach to kind of widen your window, which feels a little bit sketchy at first. And then many of the same tools you'd be using in an open approach, they make endoscopic versions of that you can put down your working channel. So in the transforaminal route, which I think is one of the sort of powerful applications of endoscopy, and one that is not available in any other MIS or open technique, you are working through what's called Camden's triangle. So it's sort of an imagined anatomic space that it's defined by the exiting nerve root at a disc level, the superior end plate of the inferior level, and the superior articular process of that inferior level. And you can see in that top right picture, it's that black triangle. But basically working through there, you can safely access the disc space, the lateral recess, and with enough decompression, the actual central canal with an endoscopic approach. So just a quick case example from a friend of mine who's now at Cornell, who does a lot of endoscopy. This is a very obese man who had a central disc herniation that he approached in a transforaminal manner. This is a slide from Dr. Hofstadter's Atlas of Endoscopic Spine Surgery, and it just kind of shows you in that top right panel, that's the Jamshidi going down to the docking point on the SAP of the level of interest, and you see how lateral that approach is. So that's 10 centimeters off of midline, coming into, you're truly going anatomically through the foramen as opposed to trying to approach it from something slightly off midline or the midline itself. And I think that's where a lot of the power of that technique comes from. So anyway, in this technique, you can see in that top left panel, you were literally docking on the superior articular process of the inferior level. And through that, you can enter the foramen, put in a K-wire, and then send those reamers down to decompress that SAP. So do bony decompression. Once that's done and you've widened that corridor, you can see the endoscope going in basically to the midline, and then it's hard to see, but there's a little structure coming out of it. It's actually a bipolar that's in the contralateral lateral recess. So this transforaminal route allows you to completely decompress the foramen as well as the central canal. These are just some intraoperative images. You can see in the top left panel that superior articular process has been reamed. So some of your bony work's already done on your way in. With this particular method, you then take the rest of the top of that SAP off, undercut the pedicle, which is this thingy. And then after that's done, you can start to see the lateral recess yellow ligament, the traversing nerve root, the exiting nerve root. And here you can even see, it's hard to see on this, but you can actually see the glistening fat of the epidural fat on the nerve root. It's a really great visualization system. And with a little bit more bony and ligamentous decompression, you can see the exiting root is completely decompressed from a ligamentous standpoint, bony standpoint, and you can even get to the annulus of any disc material that's herniated into the foramen. So this is a post-op imaging of that case that I just showed. You can see Dr. Koshlan came in from the left, was able to take out that disc material and open up the central canal. And this is an immediate post-op study too, which are kind of the ugliest, but you can see that those roots are very decompressed there. It's also a powerful tool in older, sicker people with spondylitic cervical myelopathy. So your renal failure, cirrhotic patient who's on 3 blood thinners that comes in after a fall with central cord syndrome and is a horrible candidate for any type of decompression or fusion. The endoscopic interlaminar decompression can be a powerful tool in treating those patients when done correctly with very low water pressure. So you can see in this patient, hemilaminectomy was done, complete preservation of the facets bilaterally with sufficient central decompression to allow that spinal cord to cool off. So there are risks inherent to this type of surgical procedure. So the water pressure can actually increase ICP enough to cause headaches for sure, nerve palsies at the root level, but even seizures have been reported. If you get a durotomy, they are extraordinarily difficult to repair. There are some techniques that have been published, but they're pretty wonky. So you're very reliant on that small incision to act more like a lumbar puncture than anything else. And then if you have an intraoperative bleeder that you can't control, it can force you to go to an open surgery. So how does it compare? A study that came out of the University of Washington while I was there.
John, can I?
Yeah.
So what is the irrigation system? Is it under a pump or is it?
So you can do it to gravity or under a pump. So in the cervical cases, most experienced people will do it to gravity. So they'll raise it, I think Hofstadter did it 20 or 30 centimeters above the patient's head.
Kind of like cranial endoscopy.
Yeah. Yeah. And so you tailor it to the patient and procedure. In the lumbar spine, you can use much higher pressure, and that water pressure is actually one of the advantages. As long as it's not a revision surgery, it's actually dissecting planes for you and allowing for better visualization. So the water pressure is.
So what do you do with bone bleeding? I mean, you can't put wax down. I mean, how do you?
So bony bleeding when you can use higher pressure is actually pretty well controlled with the irrigation, but you also the bovie for it is so small you can actually bovie on the bone safely and control a lot of it. But there is surprisingly little bleeding interference in those cases, at least in the lumbar spine.
John, are you going to talk about uniportal versus biportal endoscopy?
No, just so we can get I haven't seen much of the biportal stuff, so I can't comment on it with any authority. I would just be kind of presenting stuff I read, and it's also I've decided to go a little bit more broad than deep.
Chris does uniportal.
He's starting to do some biportal, but mostly uniportal. I think he's trying to do more and more biportal for the T-lift stuff, which I'm not going to get into. Or he's starting to do some like separation surgery and with endoscopy, which I think is really interesting, cool application. But it's also, I think, either the technology needs to come forward a little bit, or you have to be an incredibly skilled practitioner. I think there's certain applications of endoscopy that only come with years of experience. Like a lot of look at this amazing thing I did in endoscopy is not something that everybody should be doing in the first 3-5 years of practice, and not things that he did in his first 3 to 5 years of practice. Like I don't think he started doing cervical anything for 3 years. But this is a paper that he put out while I was there, just comparing endoscopic to MIS, lumbar microdiscs. Endoscopic surgery took a lot longer. However, the patients stayed in the hospital a shorter amount of time, and they had more improvement in leg pain and back pain, even compared to tubular surgery. So that was at the University of Washington. Meta-analyses of outcomes have not shown a definitive advantage in terms of the outcomes. So in terms of risks and complications, they have shown an advantage with endoscopy. In terms of outcomes for leg pain and back pain, they have not. So 2 meta-analyses, one in 2019 and one in 2021, failed to show clear benefit of endoscopy over open and techniques. So in my opinion, what endoscopy is good for is fusion-sparing decompression. So foraminal stenosis, treating that without having to do enough of a facetectomy that require fusion, and taking out thoracic discs without having to do a fusion. And then both ends of the patient spectrum. So very obese, very unhealthy patients, allowing them decompression and neurologic recovery with a very, very low risk profile. And then extremely healthy active patients. So there are actually a number of studies on this in Division I and professional athletes, and their return to full play and full practice is extraordinarily fast. And I've actually seen that in a number of Division I University of Washington athletes. So switching gears to navigation and robotics, another subject that's sort of near and dear to me. So robotics really comes from stereotaxis, from our brain buddies. So Victor Horsley and Robert Clark first published 3D targeting technique in 1908 in brain, and they used a Cartesian coordinate system to target, basically to torture monkeys in a sophisticated manner. There's been an evolution of image-guided spinal surgery that has led us to robotics. So we've gone from plain films that are developed in the OR in real time to very high-resolution 3D imaging systems that can now be paired with robotic arms. So accuracy matters, and that's where the importance of navigation and robotics comes in. So accurate placement of a pedicle screw is, so missing the pedicle by a little bit does not correlate well with neurologic outcomes. Obviously, if you completely whiff, there can be neurologic problems, but it does correlate well with fusion rates, adjacent segment disease, especially if a screw goes into a disc above or below your construct, the strength of your construct and your ability to correct deformity. So putting a pedicle screw in the right place seems to be pretty important. I think we can all agree on that. So before navigation was widely accepted, Gertzbein and Robbins created an accuracy system that is still used today, and they evaluated 167 pedicle screws from T8 to S1 in vivo, so post-op CTs in 40 patients. And basically, the number of screws that were truly in the pedicle without breach was less than 72% at that time. Navigation became more widely used, and a meta-analysis in 2007 showed some improvement. So their pedicle screw accuracy, reported pedicle screw accuracy is now 91% aggregate. And this is 130 studies, over 37,000 pedicle screws, so very large study. And at this point, already in 2007, you're already seeing a significant difference of accuracy in pedicle screws going in with nav versus those without. Now, this paper is a little bit hard to interpret because 65 of the papers didn't actually report the method that they used to evaluate pedicle screw accuracy, and in the other half that did, there were 35 different methods. So the most commonly used accuracy methods are dichotomous, either breach or no breach, or this Gertzbein-Robbins variance, which is essentially how far out of the pedicle you are, mostly toward the canal. The 2007 paper didn't recommend any single accuracy measurement. So another meta-analysis that came out in 2014 that was very well done. It was 30 studies with 40 data sets looking at conventional fluoro, so just getting x-rays in real time versus 2D fluoronav, and then 3D navigation, so CT-based navigation intraoperatively. And their accuracy was simply breach or no breach, so very straightforward. So a little bit outside of the pedicle is a fail, completely in the pedicle is a pass. So 9,300 pedicle screws, and oh, I lost my picture. Oh, I got it back. So pretty clear, almost linear increase in accuracy with sophistication of navigation. So you can see the conventional fluoro overall accuracy is 68%, which is interesting. It's actually lower than that initial 1990 study. And then 2D fluoronav, you get up to 84%. And then with 3D navigation, you're at almost 96%. And you can really see a difference in difficult pedicle screws. So the fluoro group in the thoracic spine, it's basically a coin toss whether or not you're going to breach the pedicle if you're using conventional fluoroscopy. Whereas with 3D nav, you're getting it almost up to the accuracy rate of the lumbar spine. And you can see there's, with 3D nav, there's pretty low variation as well. So navigation and robotics. So interestingly, the first neurosurgery conference that I ever went to was AANS in San Francisco in 2014. And in the opening ceremonies, on walks a man who kind of looks like George Costanza with dreadlocks, who is actually a philosopher and computer scientist. And in his speech, he says, look, the computational power sort of increases in an exponential fashion based on what we are doing now. Within your lifetime, computational power will be strong enough for AI and robotics to replace all of you. So that was a very nice introduction to neurosurgery by that gentleman. And more literature kind of suggests this as well. So more philosophers and data scientists agree that one of the first jobs that is going to be replaced by robotics and AI are actually physicians. And so, you know, in terms of incorporating robotics into spine surgery, I think you can resist, or you can kind of be part of the transition, you know, before you're dragged away by, you know, the cold metallic hands of an ortho spine bot. So surgical robots have actually been around in neurosurgery for a while. In 1985, the Puma surgical robot was used to basically position a brain biopsy cannula successfully. The orthopedics started using the RoboDoc in 1986 for hip replacements and cord femoral shafts. The first time that I'm aware of robotic arm being used in spinal surgery was actually Curtis Dickman at the Barrow in 1998. My understanding is he used it to position a thoracoscope for thoracic schwannoma resection. The first surgical robot that has been used widely is the Da Vinci system. So it came out in 1999 and it became incredibly popular very quickly. It's got 7 degrees of freedom. It's what's called a master-slave type of robot where it's telesurgical. So the surgeon sits at a workstation that is outside of the operative field and controls what the robotic arms are doing without interaction. And then in my experience with it as a medical student, it was a profound facilitator sleep in the OR on rotation. So in introducing robotics and spinal surgery, what do we want from a robot? So we want to capture those patients that are doing the same Google image searches that I was doing, people seeking out minimally invasive approaches for similar outcomes. We want to reduce radiation exposure to both the surgeon and the patient, as well as all the OR staff that are in there getting zapped every day. We want consistency. So we want something that is going to produce accurate results again and again, regardless of the type of patient, type of surgeon, level of fatigue, et cetera. We want to be able to do really high-end pre-op and intraoperative planning where we can see where things are going to go, where they're going to be relative to one another, and be very sure that we are actually placing them where we think we are. And the way that we are going to be very sure of that is very high-end real-time visualization showing us where things are going in space and time, active feedback on patient positioning. So not only very good patient tracker mechanism, but also a tracker that tells us if the patient tracker is off. So we know if the patient has moved and if the tracker has moved relative to the patient. And then we want deflection sensing technology. So if we're putting everything through a robotic arm and that robotic arm can theoretically move, even if that is 1 millimeter, we want to know if we're pushing too hard on it and moving it. So the first robotic system come out was Mazor, FDA approved in 2004. It was a pre-op CT or MRI that was merged with intraoperative fluoro shots, and was good for MIS or open techniques. Slow adoption of this, there were some big issues. One, it doesn't have a patient tracker, so it assumes that a patient is in the same position the whole case, no matter what, after the fluoro images are obtained. So if the patient moves a little bit, coughs, whatever it is, you can have uniformly malpositioned screws. And then it didn't have any deflection sensing technology. So you can put your instruments through its guidance tube and put too much pressure, skive with all the instruments and have malpositioned screws.
John, do you know which surgeons are behind the Mazor? Is it ortho, neuro, or?
The Mazor it's an Israeli company that was bought by Medtronic, and I'm not sure who developed it. That's a really good question. I have never actually worked with the Mazor, so that was part of my disclosure slide. The Mazor may be phenomenal, but I'll talk a little bit more about the Globus robot because I know it. So yeah, definite disclosure. I know people who use it and like it. And I think it does offer the same benefits as any other robotic system.
We have a Mazor cranial robot here that Kano used for a long time. It was basically the same accuracy as a Lexel frame. And, in resonance, Ryan, I guess, probably spent more time on it than anybody else. Didn't really, the big advantage is that you didn't have to put a big frame on.
Yeah.
Just clamp this thing on the head.
Yeah.
So potentially the patient's head was more free to move. For DBS, that means something.
Oh yeah. No, I mean it's also like tiny pedicles in a very stenotic canal, a millimeter is a big deal in the spine too. It's not quite the same as trying to hit the SDN, but so anyway, several iterations of the Mazor have come out that have addressed some of those issues. So the Excelsior surgical robot is the Globot version. That's or the Globus version. That's the one that we now have. That was designed by Nicholas Theodore and his friend Neil, an engineer at the Barrow. And then the beta version was initially sold to Globus, who then improved upon it. But like the Mazor robot, it is a shared control system. So you are in the operative field working with the robot, and has 6 axes of rotation for accuracy. I think the improvements sort of on the Mazor and other systems were better real-time visualization, intraoperative planning, so you can adjust your trajectories in a sterile fashion with basically like an iPhone type interface in the OR during the case. It has a patient reference that tells you if the patient tracker has moved, and then it has a very sensitive deflection sensing technology within the arm. Does it work, or does it help or offer any type of advantage? This is Dr. Theodore's, one of his first papers, compared 28 robotic cases to 28 open cases. There was less EBL with the robot, shorter length of stay, no difference in average operative case length or return to OR from malpositioned screws. And they actually found that the case length decreased by about 5 minutes every case. So in theory, the next 28 cases would have been faster than the open cases. This is a larger study from a group out of HHS where they looked at 1,300 freehand, 347 robotic screws. They found there was less EBL with the robot, shorter length of stay with the robot, no difference in OR time or return to OR for malpositioned screws. So they didn't compare any fancy accuracy measurements. They basically just said it's accurate enough, or it's clinically comparable. This is another one by the same group at HHS where they were actually looking at it. They were comparing it to, or they were looking at screw accuracy, not only in very nice, shiny primary surgical cases, but revision cases, and then cases that were done both in the prone position and in the lateral position. And so for all 4 of those groups, they had accuracy of 94% or better in pedicle screw placement, very little robot abandonment. So basically showing you that this is a very reliable system putting in hardware, navigating in hardware, no matter how difficult the case is or the patient. So another interesting study where this group took pooled data from 3 different institutions, and they had preoperative plans that they compared to postoperative CT scans, and they looked at the variance between their pre-op plan and the actual placement of the screw. And then basically looked at a huge number of patient factors, so obesity, gender, vertebral body level, et cetera, and surgeon factors, so experience, ortho, neuro, et cetera, and looked at the variance in screw placement, so intended placement versus actual placement, and how much all of those other factors contributed. And it only accounted for 7% of the variance in the intended placement versus actual placement, which is to say that this robotic system is reducing cognitive load. So it doesn't matter who the surgeon is or what the patient is like or what you're facing, you're going to have similarly accurate results with very high accuracy. Again, this is another study kind of highlighting that basically 600 pedicle screws. One side, it was the same 2 surgeons. One was a seasoned attending surgeon, the other was a trainee. They did a bunch of cases in a row, 600 pedicle screws. They split them evenly. One person did one side, the other did another side. Then they had a blinded reviewer analyze pedicle screw accuracy, and there was no difference between the attending and trainee. So again, it reduces your cognitive. When things are going where they're supposed to go, you can concentrate on other portions of the case. My take on it, I think 3D nav is widely accepted. We know on average it helps people be more accurate in the OR. The robot is an extension of that. I think it's already helping us. I think the robots are coming, so to speak. They're going to get better and better. They're going to be incorporated more and more. You might as well be a part of that transition as opposed to resisting it. And the reason why I like it are the things that I just highlighted in the publications. To decrease EBO, length of stay. Patients tend to have less pain afterwards, and then it allows me to focus on other things in the OR as a junior attending who's overwhelmed by everything. And just sort of a testament, an interesting testament to the value of the robot is this guy, John Weingart, is the most senior sort of skull base brain tumor surgeon at Johns Hopkins. He didn't do any sort of fusion surgery for 25 years in his career. Theodore came there with a robot. He saw it, he liked it, and he started doing lumbar fusions again.
You're saying there's hope for me?
Yeah, yeah. I thought that was incredibly interesting. Like a renowned skull base guy just was like, wow, that's pretty cool. I'm gonna start doing lumbar fusions again that late in his career. And then, do we have time? I'm going to kind of just breeze through this because we don't have much time. But basically, so I've gone through some technical MIS approaches, but there's also, it's important to think about philosophical, minimally invasive approaches. Do you need to do a deformity correction, or can you just address symptomatic levels? And then the other thing to think about is because something is an approach is described as minimally invasive, if you are doing multiple minimally invasive approaches, is it still less invasive than a traditional approach? I really like this talk by Mike Wang, who I'm sure you know very well. It's actually on this website called ViewMedi for any of the trainees. It's really good. There are a lot of kind of high-level talks on different techniques, cranial and spine. But he basically gave a talk that said posterior approach in spine surgery is best for the patient. And he gave it at the Society for Minimally Invasive Spine Surgery. And his argument is, look, you can do everything from the back. Why are you going to do a lateral incision and a posterior incision and then walk the patient around, see if they still have leg pain, then go back in, do a micro disc at the level where they still have pain, where you can just go in and do a posterior surgery and get it done and accomplish all of your goals and be sure of it through one incision. So something to consider when you're talking about MIS, what is truly MIS. So I want to thank a bunch of people, Christoph Hofstetter and Albert Telfian, who helped introduce me to endoscopic spine surgery. Salma Koshlin, he's at Cornell. He gave me those case examples for endoscopic. Nicholas Theodore, who obviously taught me how to use the robot, gave me some of the references for this. All the spine faculty here who have been incredibly welcoming and given me awesome advice and really kept me from drowning in this first year. And then Dr. Tannen, of course, for his continuous pointed critique of spinal surgery.